So good evening, everyone, and welcome to this webinar entitled Fighting Against Helicobacter pylori, experience based on 10 years of the European Registry. So we are commemorating the Registry decade of success, I would say, and we are very, very happy to celebrate this significant achievement with all of you. My name is Javier Gisbert, and I'm the principal investigator of the European Registry, and my co-chair is Leticia Moreira. She's, together with Olga Nissen, the scientific director of the Registry. So first of all, I would like to take this opportunity to thank all of the investigators that are participating in the Registry for their remarkable commitment, and it is our pleasure to moderate this fantastic webinar. I would like to inform you that this session will be recorded and you can ask questions using the questions and answer button. And of course, we encourage you to participate very, very actively. So let's start with the first presentation, which is entitled "Why and How to Participate in the European Registry," and it will be given by Dr. Michael Doulberis from Switzerland. And Michael is, I would say, one of the most active and effective national coordinators of the Registry, and I would like to take this opportunity to publicly recognize his enormous efforts to participate in the Registry. So, Michael, the floor is yours whenever you want.
Dear Javier, thank you very much for this honor. Let me share my screen firstly. Hopefully it does work.
Yes, perfectly.
Okay, so dear friends and colleagues, ladies and gentlemen, I'm going to give a short talk on topic why and how to participate in the Helicobacter European Registry. I'm going to narrate my short story, how I reached there and what impressions I have achieved within these 2 to 3 years. So that's an outline of my speech. You can see now the structure, what I'm going to talk about. I proceed to the conflicts of interest of mine and a couple of words about my bio, so as you can follow up everything up to date. I was born in Greece. I obtained a veterinary medicine diploma, and afterwards I studied human medicine, and simultaneously I achieved a PhD in IBD and microbiome. After the graduation of medical school, I decided with my wife to move to Switzerland, and since 2017, I'm implicated in the H. pylori research extensively. Professor Koundouras from Greece also inspired me and motivated me to do so. In the year 2020, I accomplished my second doctoral thesis in Switzerland, and I'm a specialist board of internal medicine and gastroenterology as well. I was contacted initially by the team of Professor Gisbert the year 2021 due to the fact that the position of the national coordinator was orphan, and due to my publications, I was proposed to overtake this new role. That was a great opportunity for me and honor, and of course, with great pleasure, I accepted this challenge. Nevertheless, the situation in Switzerland, once I overtook this responsibility, it was not the best one, I have to confess, and it is only a rarity that's a bed of roses. So I found that our country was in the bottom of the participating list of the countries. The previous national coordinator is a senior retired colleague who was no more active for the last few years. As you may be aware of, Switzerland is a country with 4 different official languages. I was not able to find an ethical approval, so I can use it as template or guidance as an amateur. Furthermore, as you also know, the cantonal system is more complicated in Switzerland. Each canton demands different approval in the worst case scenario in different languages with deviating requirements and separate informed consent forms. To make matters worse, every single submission, mutation, question, etc. demands additional money. I have to stress that the bureaucracy, administration, documentation in Switzerland is overwhelming, devastating. And just to give you a taste, doctors with clinical work in a hospital work theoretically 50 hours per week, but in real life, it's more than 60 hours, depending on the specialty. And I have personally had weeks of duty where I was more than 90 hours working. So due to this fact, it was not easy task to find colleagues, gastroenterologists who were eager to make research with us to collect patients. So many acquaintances of mine did not reply repeatedly to my mail messages or politely refused, whereas I had also cases where the doctors without any experience demanding first or last positions to collaborate or even a salary of my behalf. And on the top of that, I also had to confront personal issues with health particularities, absence of research grant, also health issues inside my family. So I decided to fight and not leave and try to win this personal challenge. The very first issue I tried to accomplish was to accelerate the process. I also used money from my pocket to translate documents and to accelerate the whole procedure. Secondly, I submitted a couple of research grant proposals, and I obtained one thanks to the previous hospital where I work, Canton Hospital Arau, to which I'm always grateful. Then I realized that gastroenterologists from Southern, after I have seen also the participating countries in the registry, from Spain, Italy, Greece, also Romania, Kosovo, have much more interest or motivation, are closer to character and culture. So I found guys from that regions who gave their consent to participate, and it worked. And in order to further re-enhance and strengthen the bonds with these the most active investigators, I invited to publish with me a couple of further H. pylori publications outside of the registry. Moreover, I tried to devote a lot of time after midnight and perform all the bureaucracy with submissions to reach the desirable result. Parallel with this above painful procedure and clinical work and being father and a husband, I try to self-upload and track all the H. pylori patients in my initial hospital, about 70. And later on, once I got this research grant, I employed a study nurse to facilitate with missing data and upload cases to RedCap server, provided that the local investigators were at loss of time. And voila, that's the situation nowadays. Our little Switzerland of almost 9 million could climb up to the middle of the ranking and remain very optimistic they're going to achieve much better results in the forthcoming years. So how's the current situation? We have currently 8 centers that have been recruited, and there are 2 additional that we expect to get included in the near future. Two additional had to be inactivated, suspended due to the fact that they did not upload any cases for a long time. I'm trying seamlessness to seek for new recruiters inside the approved centers and outside of them. Additionally, our first Swiss article is in pipeline, and 5 pan-European papers have been published with great success, I have to admit. I'm about to apply for another research grant so I can reassure this valuable study nurse function for the long term, and a further advertisement of our work through social media and scouting within scientific meetings and congresses is a first goal of mine. I'm going now to proceed briefly to the first Swiss data that we share for first time in public. That's an extraction of December 2023. We have identified 486 cases of adults infected with H. pylori. 88 of them were treatment-naive patients, and almost 90% of the cases were composed of two schemes, either the French scheme with amoxicillin and clarithromycin, half of the cases, and the single capsule bismuth quadruple therapy, also known with the commercial name Pylori, 42% of the cases. Beyond that, we identified 280 cases that had a confirmatory eradication test, either breath test or stool test in most cases, and we were able to perform with these cases so-called effectiveness analysis. So the overall effectiveness in Switzerland yielded a very satisfactory 92%. And the lowest effectiveness was recorded with triple therapy with amoxicillin and clarithromycin. It was 82% for 7 days, and the overall percentage was amounted to 87%. The single capsule bismuth quadruple therapy effectiveness was 97%. And regarding PPIs, a couple of comments. The overall eradication success was almost 91%. And the majority of cases that were very successful were either with standard or with high dose. In a nutshell, I would like to share with you the advantages through this pleasant journey with the registry. First and foremost, and allow me to tell you, it's an honest confession and unpretended. I'm very honored to belong to a great scientific family with objectively strong bonds, devotion, and with exceptional professionality and support. Besides this, I was able to earn valuable compressed experience in ethical, bureaucratical, administrative issues. Moreover, I could participate in a plethora of papers, posters, oral presentations, including high impact factor achievements, such as gut or clinical gastroenterology hepatology. I'm allowed to tell you that I have been established since then as a H. pylori expert in Switzerland, and I get consulted not rarely for complex or refractory cases by other colleagues. I could also boost my CV and obtain better research and clinical practice collaborations. And I have to admit that I have many patients who seek for my advice due to my expertise, either from Switzerland, even from abroad, from France, from Germany, from Greece, etc. So, to summarize, the Helicobacter European Registry is a large scientific family originally born in Spain and is exceptionally friendly, supportive, with proven, I stress that, quality of research work. The registry is also a strong database exceeding 70,000 patients with virtually all profiles and settings, which gives birth to great potential to better comprehend and treat the H. pylori infection. So the active participation really boosts manifold CV, know-how, and socializing. And as a take-home message, despite unexpected events, difficulties in life, once goals and motivations are present, somehow and somewhen dreams come true. I would like to give my endless gratitude to people who supported me from the very beginning, directly and indirectly, from Professor Gisbert till my family. Thank you for your attention.
Thank you so much. Thank you very much, Michael, for your very, very nice presentation. So let's move now to the next presentation, which is entitled the European Registry, the Spanish Experience and What is Coming Soon. And it will be presented by Javier Tejedor. Javier Tejedor from Spain is, I think, one of the most committed regional coordinators in our country. And you probably might know that Spain is responsible for the inclusion of almost a third of the patients in the European registry. So you can imagine the importance that Spanish participation has. So Javier, the floor is yours whenever you want.
Okay, thank you. Thank you, Javier, for your presentation. Can you see my screen?
Yes, perfectly.
Okay, thank you. Good afternoon, everyone. First of all, I like to thank the scientific committee for the opportunity to participate in this webinar. I want to talk about the Spanish organization and a brief summary about last national studies. Well, this is probably one of the biggest GI registry with more than 70,000 patients in inclusion. And also the participation has increased all over the years with more than 11,000 patients in last year. All this is possible thanks to a big organization. And here there is the scientific committee who deal with the coordination and ensuring the high quality scientific of the registry. Spain is the most active country among 38 countries participating, with more than 26,000 patients included. Russia and Italy go in second and third place, respectively. Also, it was to say that Azerbaijan, Lithuania, and Ireland achieve a significant number of patients every month, as we can see in this newsletter. Here, there is the map of Spain with a big green area who corresponds all regions participating in the registry. And here in Spain, there is a national coordinator, Luis Hernandez, and here there is the rest of the team. There are 20 regional coordinators who try to promote the registry among the rest of the college, encourage them to participate to achieve a big number of the patient inclusion, and they lead a local investigation on each region. Every 3 months, the national coordinator sends us a newsletter about the patient inclusion by regions, most active recruiters, and all patients included by hospital, as we can see in this graph. Some papers have been published with Spanish results, as we can see here. There are 2 of them. First of them about the effectiveness of first and second line treatment in Spain, published in Antibiotics, and the other one published in Helicobacter about the smooth quadruple regimen with tetracycline or doxycycline versus 3-in-1 single capsule as third-line rescue therapy for Helicobacter pylori infection in Spain. Now I'm gonna do summarize briefly 2 national studies presented in last GI Congress of AEG. The first one about the time trends and effectiveness of first-line treatment for Helicobacter pylori for 10 years in Spain. As we can see in the blue area in the graph, the triple regimen did decrease or 37-40% to less than 2% in last year, especially from since the 2018 and 19. On the other hand, the quadruple therapy as concomitant and bismuth therapy has increased up to 37 and 58% respectively in last year. Here there is a graph of PPI dosage. As we can see, the green area, the low dose PPI is the most frequent dosage. However, standard and high dose PPI have increased in last year as results and recommendation said. Nowadays, most patients have a treat with 10-day and 14-day therapy for eradication of HpEuReg, according to a bismuth quadruple therapy and concomitant therapy, respectively. This slide shows the eradication rate according to a Spanish region. Over 90% of eradication rate was only obtained with 10-day bismuth quadruple therapy and 14-day concomitant therapy. Also, a shift to a longer treatment and high dose PPI were associated with an increase of the first-line treatment effectiveness for 84% to almost 97%. Here, there is another study, national study, presented in last AG Congress about the bismuth quadruple single capsule compared with the concomitant therapy in 12,000 naive patients for 10 years. As we can see in the graph, the single capsule bismuth quadruple therapy 4 and 3 times a day schedule show a significantly better overall cure rate than 10 and 14-day concomitant therapy. In case of safety, the side effects were more frequently in group of patients treated with 14-day concomitant therapy than 10-day concomitant and single capsule bismuth quadruple therapy. So we can conclude that the single capsule bismuth quadruple therapy is the most effective first-line treatment, and this is better tolerated than 14-day concomitant therapy with less side effects. In the multivariate analysis, compliance therapy, also indication and geographic center were significantly associated with a cure of infection. And thank you so much.
So thank you very much, Javier, for your fantastic talk. And so let's, well, I would like to say that we will leave the questions at the end of the 3 presentations, and in this way we will be able to manage more efficiently the time. So let's now move to the last presentation, which is entitled "What Have We Learned from the European Registry After 10 Years?" And it will be given by Paulius Jonaitis from Lithuania. And let me say that Lithuania is, I think, the best example of how a relatively small country with relatively low population can become one of the top recruiters of the European registry. So we are very fortunate to have here Paulius, that we will show how he has done this.
Thank you again. I will now share my screen. Okay, can you hear me and see the slides?
Yes, perfectly.
Okay, so good afternoon, everybody. Thank you, Professor Gisbert, for introducing me. I am quite grateful to give this talk today, and I would like firstly to thank the whole registry, DICE Europe and AIDA teams for organizing this webinar. So in my talk today, I will try to summarize the main achievements as well as the lessons that we have learned during the first 10 years of this European HP registry. So again, firstly, we need to thank the members of the scientific committee, with Professor Gisbert, of course, being the main investigator, and his whole team, who have done an amazing job in bringing the registry where it is actually today and after these 10 years. During the 10 years, the registry has managed to cover most of the Europe, and as we can see in this map, there are 38 countries currently participating in the European HP registry, with more than 400 investigators involved. And of course, each of the participating country has its own main national coordinator, and here we can see all of them. So the first lesson that we have learned during these 10 years is that the participation in the registry has been constantly increasing. We can see a constant growth in the participants and can notice that currently we have more than 73,000 patients included. And it is actually quite spectacular to notice that even after 10 years, in the year 2023, the inclusion of new patients was the largest during the whole history of the registry. Regarding the number of patients included by country, of course, Spain is in the leading positions, but there are also other countries such as Italy, Azerbaijan, Slovenia, Lithuania, Norway, Ireland, and other countries with quite good inclusion numbers, over 1,000 patients. The second important lesson that we have learned is that the registry had a significant impact on the scientific production during these years. All of the members of the registry managed to prepare and publish 40 peer-reviewed publications, including local analysis in various participating countries, helping to better understand local situation. And actually later I will be giving some Lithuanian data as well. What is more, over 100 abstracts were presented at national and international congresses, some of which were selected for oral presentations or were even awarded as the best ones. And of course, let's not forget that Olga Nissen, who is a scientific co-director of the registry, was awarded the Rising Star Award by UEG this year for her enormous work and contribution regarding the registry. So now let's quickly run through the most memorable and acknowledged publications during the last 10 years. I will not go very much into detail about these publications because all of them are available online. Probably the first one and the most important one of the publications was published in the year 2021 in journal Gut, and it was the first analysis of the first 5 years of the registry, and it was the first such large-scale analysis analyzing HP first-line treatment prescriptions, its trends and outcomes. Another important publication in the same year was published in the American Journal of Gastroenterology, and it focused mainly on the adverse event profiles in 22,000 patients from the registry. In the year 2022, we had 2 very important publications. One was published in Clinical Journal of Gastroenterology, and another one in Frontiers in Gastroenterology. And I think both of these manuscripts are quite important because they revealed a great heterogeneity in H. pylori diagnostics and treatment in various participating European regions. Focused on the main issues, as well as managed to highlight the importance that the registry provided us in order to achieve better treatment outcomes in management of HP infection. Moving on to the year 2023, this manuscript in the gut focused on the superiority of bismuth 3-in-1 single capsule prescription 3 times a day, also considering other factors such as PPI dosage and treatment duration. The same journal published another manuscript in the same year, which was the first publication of such scale focusing on the empirical rescue treatment and its optimization in the cases of primary and secondary treatment failures. This year, we already have 2 excellent manuscripts, of which one was published in the American Journal of Gastroenterology and mainly focused on the HP antibiotic resistance, as well as provided some great recommendations on treatment prescriptions in order to overcome this increasing issue. And the other one was published in the UEG journal and focused on the importance of PPI dosage and treatment duration in order to achieve better HP eradication results. So these were the main scientific production highlights during these 10 years. Of course, not to forget that there were other great manuscripts published during these 10 years. Now let's move on to probably the most important part of the talk. What lessons have we learned regarding H. pylori diagnostics and treatment during these 10 years of the registry? So the first lesson that we have learned is that triple therapies have failed to reach optimal eradication effectiveness in many European countries and should not be prescribed in areas where it is ineffective. In this chart, we can see that overall, during the last 10 years, triple therapies have been prescribed in 40% of the first-line treatment cases, and none of them managed to achieve optimal overall 90% effectiveness mark. On the contrary, too many quadruple therapies. The second lesson is that the bismuth quadruple therapy is an effective first-line option when available. I deliberately underlined the part when available because, of course, bismuth compounds are currently now available in many of the participating countries, but this was not always the case. And in some countries, bismuth compounds got on the market only very recently, as well as, for example, the 3-in-1 single capsule is still not available in many countries. Here we can see the effectiveness of first, second, and third line prescriptions of various bismuth-based quadruple therapies. In the first line, a lot of the schemes are over or very close to the optimal 90% mark, with the overall effectiveness over 90%. Not surprisingly, in second and further lines, the efficacy declines, but still remains quite good with these bismuth therapies. The third important trend to notice is that during the 10 years, the prescription frequency of bismuth and non-bismuth based quadruple therapies have taken over triple therapies. Here we can see that from the year 2013 to the year 2023, the frequency of triple therapies, of which the standard triple therapy with clarithromycin and amoxicillin was of great importance, had a decrease in prescription frequency from 50 to around 20%, whereas the frequency of most frequently prescribed bismuth-based quadruple therapies has increased from less than 1 to 40%. And the frequency of non-bismuth-based quadruple therapies has remained quite stable throughout these 10 years. This map clearly represents that triple therapy with clarithromycin, which is colored in red, was the most frequent first-line empirical prescription in many countries in the year 2013, with the exception of most Western and Southern European countries. And there was a clear change in the year 2023, where we clearly can see that bismuth quadruple therapies in dark green, non-bismuth-based quadruple therapies in light green, and triple therapies with addition of bismuth in pink have clearly taken over. Of course, there are still quite a few countries where standard triple therapy remains the most frequently prescribed first-line option. Another important lesson learned is that H. pylori eradication therapy should be prescribed for 14 days unless shorter therapies are proven effective locally. In this chart, we can clearly see that 10 to 14 days treatment duration has been superior to 7 days treatment in terms of overall efficacy during these 10 years. And here we can see a shift to longer first-line treatment durations, which has been quite noticeable since the year 2017. With the new release of the updated 5th Maastricht Consensus Report guidelines. And during the last 6 years, 10 to 14 days treatment durations have been prescribed in over 90% of the cases. We should also not forget that the use of high-dose PPIs twice daily increases the efficacy of most eradication therapies. And this is clearly visible here. Standard and high-dose PPIs help us to achieve optimal first-line HP eradication rates. And this has led to an increase of standard and high-dose PPIs prescriptions throughout the years. However, we can still see that low-dose PPIs remain the most frequently prescribed regimen in first line, so there is still room for some improvements to be made. And of course, it would be unacceptable not to mention that treatment compliance is the most important factor in successful H. pylori eradication. In this chart, we can clearly see the effect of treatment compliance on these popular first-line prescription success rates. For example, good compliance almost doubles the success rate of standard triple therapy. So, to conclude, all of these lessons have led to changes in treatment prescriptions and constantly increasing first-line eradication effectiveness rates. The overall first-line treatment effectiveness by modified intention to treat analysis has been constantly increasing throughout these years, from 85% in the year 2013 to 94% in the year 2023, which is a great result. In this map, we can see that in the year 2013, the effectiveness of most frequent first-line prescriptions were quite heterogeneous among European countries, and not many countries had optimal eradication rates, which are marked in green color. And of course, we wanted more countries involved in the registry, as well as more green-colored ones, right? Well, that was achieved quite nicely during these 10 years. We can see that in the year 2023, there were a lot of green-colored countries, as well as many new countries involved in the registry. Of course, there is still room for improvement in some countries, but I am sure that with these results and with the help from the registry, they will manage to improve in the near future. So these were the main achievements and lessons of the HP registry during the last 10 years. For the last part, I would like to use the opportunity and present some local data from my home country, Lithuania, which could probably correspond to the surrounding countries as well. So what lessons have we learned in Lithuania during these 10 years being involved in the registry? Firstly, even though we are quite a small country with only 2.7 million inhabitants, with the efforts of our local professor Paulius Jonaitis spreading the word, as well as from the help from other local gastroenterologists in different cities, we can be a great example of high recruitment in a small population. In this chart, we can see the recruitment per 1,000 inhabitants in the registry. With 2.1 million inhabitants, Slovenia is in the leading positions and Lithuania is not that far behind. Both of these small countries are quite ahead of Spain, which is, of course, has included the most patients overall, as well as other countries. In the year 2021, with the help of other HP registry investigators, we published a local analysis manuscript focusing on the first 7 years of being involved in the registry and including 2,000 patients. It was concluded that the overall effectiveness of most frequently prescribed first-line regimen, which was the standard triple therapy with clarithromycin and amoxicillin, was 91%, whereas it was 92% for the most frequently prescribed second-line regimen, which was triple therapy with levofloxacin and amoxicillin. So these were quite good results. However, we wanted to look more deeply into the main local issues and compare them to the Maastricht guidelines. The first issue was a very low confirmation post-eradication testing in only 29% of all cases included in the registry. What is more, there was a high use of serology as a primary diagnostic method. Even worse, the use of serology as a confirmation of eradication post-treatment in 16% of the cases. I need to notice that urea breath test became available in Lithuania only in the year 2018 and has been increasingly more available since then, and the use of stool antigen test has also been increasing. Other issues were inadequate dosing and frequency of PPIs, short treatment durations in the first-line therapy, as well as the repetitive prescriptions of the same regimen after the treatment failure. So this analysis led us to the conclusion that there still was a lack of correspondence to international guidelines. After this analysis, a lot of effort has been put into spreading the word about the findings from the registry, informing local gastroenterologists and general practitioners about these mistakes and how to avoid them in order to achieve optimal management of HP infection. Thanks to the HP registry team, I was able to have a look on the updated Lithuanian analysis, adding additional 3 years since the manuscript was published. So did we make any improvements? During the last 3 years, we managed to include additional more than 2,000 patients to the registry. The overall frequency of standard triple therapy in first-line treatment in the prescriptions has gone down from 91 to 83%, whereas the overall frequency of quadruple therapies in first-line treatment prescriptions has increased from 5 to 13% compared to the first 7 years. And the effectiveness of most of these prescriptions are now optimal over 90%. Bismuth quadruple therapy with amoxicillin and levofloxacin was taken over by quadruple therapy, adding bismuth to this regimen since the year 2020 in the most frequent second-line prescription. Treatment duration has clearly shifted to 10 to 14 days. And another important thing is that there was an overall increase in confirmation post-eradication testing from 29 to 39%. And the most important thing is that the efficacies of the main first and second line prescriptions have remained optimal during the last 4 years. Closing in, I would like to show the last graph, which I found quite interesting. Here we can see the efficacy trends of the main first-line prescription in Lithuania, which is the standard triple therapy with clarithromycin and amoxicillin. Of course, there is a trend of increasing efficacy, but what is even more interesting is that after our local analysis in year 2021, and spreading the results to the local doctors, we can clearly see that the efficacy of the standard triple therapy has been increasing since then and has reached 95% in year 2023, which is an excellent result. So this just shows you that the results from the HP registry helped us to increase the efficacy of this regimen, the standard triple therapy, which is now abandoned in many European countries due to high clarithromycin resistance. For my last slide, I would like to quickly mention that your European H. pylori registry is currently involved in two European Union funded international projects. The first one is called AIDA, and it has a goal to develop an artificial intelligence tool for a better gastric cancer inflammation diagnostics and treatment. And the second one is called TOGAS, which has a goal to find the best strategy for gastric cancer screening implementation in European Union. So with the enormous amount of data and help from the registry, I think that this European HP registry will contribute highly to both of these projects and reach excellent results and outcomes. So this was it from me. If there would be any questions, I will be happy to answer them. And probably now we should move to the discussion part of this webinar. So thank you once again.
So thank you very much, Paulius, for your very inspiring talk. And let's move now to the questions and answer sessions. I invite Leticia also to join our session, which is probably the most interesting for the audience. And I also encourage all the speakers and also the audience to use the questions and answers button to participate very actively in this session. And let me start with one question for Michael. So how do you have shown that, I mean, the results are heterogeneous in your country with relatively low efficacy with the standard triple therapy and better results with bismuth-based quadruple therapy. So how do you perform? How do you choose the empirical eradication treatment in real life in your country now in Switzerland?
Thank you for the excellent question. So I'm a very pragmatic person. Once I have patients stemming from Central Europe and they're not exposed to abuse of antibiotics, they don't have any previous allergies, etc. I try the traditional classical French SIM with amoxicillin, clarithromycin, mycin, and it usually works for 10 days. If I have patients that come from the Balkan territory, Mediterranean, Middle East, and I suspect that they have some resistances, I start directly with Pylera since we have the privilege in Switzerland. And I'm very satisfied. 10 days, I underline the importance of compliance, of smoking cessation, and sometimes I try to make improvements with PPIs. If I see people that are European and have a suspicion of a cytochrome 2C19 mutation fast metabolizers, I may use esomeprazole over pantoprazole. And on the other hand, if I do have a clopidogrel or immune suppression in the background, I may give the pantoprazole, which is more reliable.
Excellent. Thank you very much for your detailed answer. So I have another question for, please interrupt me if you have any other question. This is for Javier from Spain. So why Spain achieves a high level of participation, being the most active recruiter? What is, in your opinion, the most important difference compared with the overall registry?
Thank you, Javier. Well, I think the importance of the national, regional coordinators and the scientific committee to achieve a big networking in Spain and to promote the registry with events like this and present high quality studies in international and national congress. Well, this commitment of the teamwork with for the registry is the base of this success.
Thank you very much. And another question for, in this case, for Paulius. So what can we, do you think, what can we anticipate in the next 10 years of the registry? Can we expect some growth and success? Because we very commonly receive a specific question, which is, are you going to stop the registry, I mean, right now, or are you going to continue with the registry another 10 years or perhaps 20 years? So what do you think are the main benefits of continuing the registry over and over instead of, I mean, stopping right now?
Thank you for the question. I mean, why stop? We just saw this chart. The year 2023, we had the most participants included throughout these 10 years. So this just shows you that the participation is increasing and the interest in participation is also increasing. It's really difficult to predict what we can anticipate in these next 10 years. But in my opinion, I am sure that there are still a lot of patients to be included, as well as many countries who want to be included in the registry. Also, not to mention that, of course, this was not mentioned during the presentation, but there is this World HP Registry, which is now currently running. So this means that patients from other continents also are being included in this same style of registry. And we will be probably able to compare the data from different regions, different continents. So which means, again, more publications, more scientific data. And of course, the European Union projects, which will be running for the next 4 to 5 years, the registry will contribute highly to it. So I'm sure that in the next 10 years, we can expect, I think, if not higher than, let's say, the same great success from the registry. And I'm sure that it will still be running and going in this next 10 years.
Thank you. In this respect, I would like to emphasize that the registry is not, I mean, it's not something which is static, but is changing through the time. And this is probably one of the most relevant advantages, because everything is changing. So the resistances, the antibiotic resistances are changing. We can have now perhaps have 15% clarithromycin resistance, and in 5 years, it could be much higher. The rate of resistance, or for example, the use of the different treatments are also changing. So I think the only way of knowing and being aware of our mistakes are precisely to audit our practice, our clinical practice, and in this way, and this is in fact the only way to improve for the future. I have, and please, Letty, interrupt me if you want to ask anything.
Yeah, well,
Anyone to mono.
Thank you very much for all the great presentations. Sorry, and Javier, I think that you and me will be retired, and the registry will be alive. So I'm pretty sure about it. So in fact, I want to emphasize, that what Paulius just said about the World Helicobacter Pylori, and the success of this European registry just opened the doors to the world expansion. And in fact, here, and you can see, I have Diego Reyes, that is the coordinator of the Latin American registry. He's here 1 month here in Spain with us, but we are just starting this great collaboration worldwide, and this will help us, as just Paulius said, to compare, to join the scientific data, and finally improve the treatment in our patients. So we have, Javier, 2 questions from the audience, and the first one, Joao Macedo said, how can we contribute with clinical data for the Helicobacter registry of our institution? Will you send us these presentations? They were excellent. Thank you, Joao. I don't know, where are you from? From Portugal, from Brazil? But we can send, in fact, we can write in the Portugal, Azores. Okay. Okay, so we can now write directly in the chat the national coordinator and the email of it's his email, so you can directly contact him or contact us through the website as well. And the second question is for the speakers. Hi, it seems that in the registry, entries without post-treatment testing are allowable. Overall, across all countries, what proportion of the entries didn't have repeat results? I think Paulius, you mentioned.
Yeah, I can try to. Oh, of course, I think it's quite. It quite varies among countries, so I'm not sure about other countries, but as you saw from my presentation, we have this issue with low confirmation of eradication, which was only in approximately a third of the patients. So again, after this local analysis and then spreading the results, we managed now to slightly increase this number. I'm not sure where this issue comes from. So it could be because the patient gets the treatment and that then just simply gets lost to follow up. After getting better, it could be also an issue that the gastroenterologist or general practitioner who prescribes the regimen does not recommend the treatment confirmation test after the treatment. So there could be some issues, but again, I mean, only by doing such webinars and spreading this data, spreading the recommendations and guidelines, we only in such a way can overcome this issue. So that is how it is in Lithuania. I'm not sure, maybe Professor Gisbert will be able to answer how it's overall in Europe, this follow-up after the treatment.
In this respect, and thank you, Paulius, that's precisely the reason why we use the modifying intention to treat analysis to show our results and to share with the scientific community, because as you know, modifying intention to treat only takes into account those results that have been received, and in that way it is more comparable with the real clinical practice. Otherwise, if we would use the intention to treat, the pure intention to treat, this eradication rate would be much lower, specifically in some countries, as you stated. So thank you.
Javier, we have another question from the audience. Luis Fernandez Salazar from Spain. Have we got some indirect data about what are our colleagues in primary care managing HP infection? Are they participating in the registry in any country? And second question, any future data about reinfection? So I don't know if one of the two Javiers wants to answer.
Probably, Javier, you can answer better than me about this general data of the registry.
Well, at the very beginning, we thought about the possibility of including the primary care practitioners also in the registry, but we finally decided that trying to be more homogeneous and compare with other different European countries, it wouldn't be feasible. So the only way was to include only gastroenterologists all around Europe. And in this way, it could be more comparable. And obviously, the things can be different. I must say that, for example, in the Madrid area, where we have a lot of educational programs up and running, the scientific level of the primary care is, I would say, exactly the same, not lower at all compared with the gastroenterologists, with the so-called specialists. And I think it could be very interesting to compare in the future, but at the present time, we don't have any data to do that. And in this way, I would like also to emphasize that obviously we have excellent results, higher than 90% eradication rate, so much higher than the desired threshold of 90%. But these results perhaps are not, let's say, exactly or representative of the real clinical practice in all the country or all the countries, because we are participating very, very, very motivated gastroenterologists in the registry, and probably the results are better. And this will be the case also in primary care. Thank you. Do we have any other question from the audience, Letty? If not, no. I have still. So I would like to. We have been talking about the changes, the resistances, and I would like to ask Paulius, because he has shown that still there are some areas in Europe where the standard triple therapy is still quite effective with more than 90% cure rates. So how do you assess the clarithromycin resistances? Do you use in clinical practice? You just test whether the standard triple therapy is effective, and this is, I mean, in fact, the most important proof of the concept of that it is a good treatment.
Actually, on normal basis, we do not test the resistances. Actually, it was done in the year 2017, I think, or 2016, and it was tested the local resistance of HP. So it was still lower than 50%, the resistance of clarithromycin. But again, I think the data from the registry just proves that, because we have still excellent cure rates with this triple therapy with clarithromycin. So probably, again, in the year 2023, it was still should have been less than 15%, but now we are again planning to do some small studies on the local clarithromycin resistance, just to check how it has changed since the last assessment was done. So we will see, but I would assume that it's still, according to the results of the registry, it would still should be less than 50%, and probably in other countries where they use this regimen, probably it's still effective there. So again, there are a lot of countries with this problem, but we should not forget that there are countries who still have this low resistance and still can use this triple therapy.
Excellent, thank you. And for Michael, we have been talking about the eradication, the test used to confirm the H. pylori eradication rate, and it is quite heterogeneous. Paulius has told us that the serology is still using in a relatively small proportion of the cases. What is the case in your country, Michael? What is the most widely used eradication test for confirmation?
Thank you again, dear Javier, for the very interesting question. And I would like to include that in affinity to the previous question about the underreporting of eradication testing. In Switzerland, there is the particularity that the family doctors would like to perform the stool antigen monoclonal testing for the eradication confirmation. So it's only in a minority of cases where we do that by ourselves. If the patients do not have any family doctor, then we may do that. But if we do that instead of the family doctors, we are going to miss a lot of referrals in the future. So it's a mutual respect, so to tell it in a discreet way. And sometimes there is a big delay till we got the results from the family doctor, the laboratory results verifying the absence of Helicobacter. So we may have a delay to upload that to the server. The Swiss people, I have to say, they prefer the stool antigen method, although both are endorsed by all the guidelines, breath urea test and stool antigen. Swiss people want to send it by post and it's accomplished. Don't want to come for another consultation and have a special preparation for the breath test, so they prefer the post way. It's also cheaper and they don't waste their time. Mediterranean people I see, or East Europe, Middle East people don't want to have anything to do with stool. They prefer the breath test because it's cleaner and they don't matter about the waste of time. So it's a political or cultural issue. Both of the methods are equally well with specificity and sensitivity above 90%, so acceptable methods. Serology I do perform only in a very, very rare situations when I want to exclude Helicobacter under PPI. So it's only to exclude because we know that the active infection, the past infection cannot well get discriminated by means of serology. Thank you again.
Thank you, Michael.
We have a last question from the audience, if you allow me, Javier. So Vinicius Magalhaes Rodriguez said, congratulations for the excellent lectures. Please, what is your opinion about PCABs instead of PPIs? I don't know if we have any experience at all here in Europe, but Javier?
No, that's precisely the future. I mean, we don't have experience because, as you know, vonoprazan is not commercialized in Europe in general, and we only have experience from the East countries and recently from the United States. And let's say the limitation is that the very good results obtained in many Asian countries or East countries has not been replicated in the United States, and also with the collaboration of some European countries in that study, that randomized clinical trial, because the results were not, let's say, fantastic, didn't achieve the 90% eradication rate.
So we don't have any other question. Only I want to say that please join us and follow us in social media, the Helicobacter pylori Twitter account, and also the AIDA social media for the project that is already in the chat. Please follow us, and Javier, it's your turn. Thank you.
Thank you, Letty. It has been a great pleasure and an honor to share together with Letty and you this webinar. And I would like to thank the speakers and also the audience for your interest in presentations and questions. So thank you very much. Thank you. Bye-bye.
Thank you, everyone.
Thanks.
Thank you very much.